All right, good morning, everybody. Thank you so much for tuning in. My name is Dane Binder. I'm the Chief Operating Officer here at Sierra Tucson. I've been with Sierra Tucson for about 3 months now. In prior roles, for the last 10 years, I've worked as a lot as a crisis mobile team provider, as well as a director overseeing inpatient crisis, inpatient detox, and inpatient psych, both voluntary and involuntary. So this is really a topic that's very near and dear to my heart. Suicide prevention is something I've been very passionate about for a very long time. And I'm just really pleased to be able to share a little bit about some ways that we can help kind of keep our community safe, especially those who are experiencing depression, thoughts of self-harm, and thoughts of suicide. So let's go ahead and get started. So this presentation is for anyone struggling with depression, self-harm, or suicidal ideation. It's also for family and friends of any one of the above. And it's also for healthcare providers treating those with depression, those who are just a little bit more curious about ways that we can kind of keep our community safe and want to learn a little bit more about suicide prevention. So as for things we'll be covering, we're going to define harm reduction. We're going to review some statistics related to suicide. And then we're going to talk about means reduction as a way of preventing suicide completions. So before we jump into this, I want to define a couple of terms that you'll hear me say. When I talk about suicide completion, that's something that we talk about in our industry as a way of just explaining when an act of suicide has been completed. We don't call it successful suicide, obviously, because that's not something that is trauma informed. We don't call it, anything other than a suicide completion. And that's just a way of noting that someone has indeed killed themselves when attempting to kill themselves. So a little bit about harm reduction. So the World Health Organization, doesn't have a very clearly defined definition of what harm reduction is. However, it is known as a set of activities that are intended to minimize the negative physical and social impact incurred by the behaviors related to maladaptive behaviors. So that's just a really fancy way of saying what sorts of things can we do to help keep people safe, knowing that these things like suicide, self-harm, are realities. What can we do to kind of minimize the harmful effects of that? So as it pertains to suicide, a large portion of harm reduction strategy is generally known as means reduction or means restriction, which is a vital portion of a comprehensive approach to suicide prevention. So essentially, what we want to do is we want to make sure that the way that people might kill themselves, we want to take away the method that they've opted to pursue to keep them safe. So if someone has thoughts of wanting to kill themselves by a gunshot, we want to keep the guns away from them. If someone wants to has a plan to kill themselves by overdose, we want to take the pills away and keep them locked away. So that's a little bit about what we're talking about. So harm reduction with respect to suicide and self-harm, these things are part of our world. So we as harm reductionists really are focused on finding ways to minimize the harmful effects of that. We're trying to keep people alive. So there are a couple of things that we can do when we encounter someone who may be suicidal or having thoughts of self-harm or maybe self-harming to minimize the harmful effects of those things. Harm reduction does not attempt to minimize or ignore the real or tragic harm that's associated with self-harm and suicide. So we do recognize that it is a very tragic and real thing. We're not trying to minimize that whatsoever. So when it comes to suicide statistics, we're going to visit this slide a little bit later, and we're going to dive deeper into the numbers and how they came to be or how they arrived at these numbers and some of the story behind them. But I did want to kind of preface the presentation by just kind of laying a foundation for how frequent it is. So suicide is, in fact, according to the CDC, the 10th leading cause of death within the United States. So it's a very serious problem. And oftentimes, we don't hear a lot about it because things like the COVID pandemic, things like the opioid pandemic, those things really capture the headlines. But suicide over time really has hung around within the top 10, and actually it's much higher rate, it's much higher leading cause of death for younger folks in particular. We're talking about ages 10 to 34, and then additionally 35 to 54. After 54, we see a little bit of a tapering off on suicide rates, but it is still, overall, the 10th leading cause of death in the United States. So if I could bring your attention over to the right side as you're looking at your screen with firearms in the bold blue, Firearms account for slightly more than half of all suicide deaths. And so really we're going to talk a lot about why it is that firearms are so lethal and why they do account for more than half of all suicides and what we can do to keep people safe. A note about firearms. I know that the Second Amendment and guns in general are a very political topic for whatever reason. So I did want to make sure that I address that this presentation is not an argument that's pro-gun or anti-gun. We are going to talk a lot about guns and their role in suicide completion, but really all we're talking about is the reality of the role that guns play in suicide completion. So just to be really clear, I'm not making any arguments for or against having guns, just being really factually based about the role that they play. So there was a study out of Harvard. There was an article published out of Harvard through their Youth Violence Prevention Center about the role that guns play and the risk of suicide as it relates to access to guns. So essentially what they're saying is that in places where exposure to guns is higher, more people tend to die by suicide. So if you look at the table here, we talk about the states with the highest rates of gun ownership and the percent of households with guns, you actually end up seeing a lot larger number of deaths by firearm than you do in rates with states that don't have access to guns quite as much. And that may seem like a pretty obvious statement, but it is actually pretty important to recognize this. So essentially, it's not so much about if a state has high rates of gun ownership or not. Really what we want to break down is, does the household that the person is living in who's experiencing suicidal ideation, do they have access to a gun? So it's really not so much about the state's rights and the amount of guns available. It's just about the specific individual. Do they have access to a gun? How readily available can they get a firearm? Even if they were blacklisted from a firearm shop, if they had a background check done, are there gun shows or that they can go to and purchase one without a background check? Do they have an immediate access to a firearm from a friend who might be willing to lend it to them, or a family member? These are really important things to consider when we're talking about minimizing the likelihood of a fatal suicide attempt. So when it comes to mortality, what we're looking at is, that firearms and suffocations and poisonings tend to be pretty successful means of completing a suicide. So as you can see, the number of firearm suicides and suffocation suicides are much, much, much higher than the poisoning suicides, which is actually a pretty common way that people attempt to kill themselves. But poisoning is not typically a completed attempt. It can be, but not always. So as harm reduction strategists, we're really interested in restricting access to firearms and to ligature risks and suffocation risks. The case fatality rate graph that you see here is a percent by suicide method. So that is to say, if someone attempts to kill themselves by self-inflicted gunshot wound, this chart out of the American Journal of Public Health indicates that there's an 82.5% likelihood of completing that suicide attempt by firearm. I've seen different publications that say it's actually closer to 90 or 95%. So that's a really high likelihood that if you put a gun into someone's hands who is suicidal, if they are going to attempt, it's almost always going to be a fatal encounter, as opposed to someone who tries to cut or poison themselves, where you see a much lower rate of suicide completion, which are these two numbers down here, 1.5%, 1.2%. So really what we're trying to do is just lay a foundation by showing you this graph and this chart, trying to just kind of show you how fatal the different types of attempts can be. So poisoning by gas has a pretty high completion rate, jumping has a very high completion rate, suffocation and hanging, drowning and submersion, and then of course firearms is the leading. And a note on drowning and submersion, though this is a very fatal way of killing oneself, the fatality rate is very high. Something to note is that it can be kind of difficult to drown yourself. So generally, if I'm encountering someone and they say, yes, I have a plan to kill myself, I'm going to drown myself. When you dig into that plan a little bit, generally it's not as well thought out. Sometimes it is, and that's very alarming. So, we consider that to be very high risk. Some people say, well, I'm just going to stick my head in the bathtub. And that's generally not something that, typically people are very successful in. Still something to be concerned about, but not as concerning as if someone said, yes, I have a gun in my house and I plan to shoot myself tonight. So these are types of things that we look for when we are encountering someone who's suicidal, so that we're trying to figure out, kind of what's the best way we can keep this person safe. I have actually a friend of mine who's an ER nurse, and we were talking about the role guns play in suicide attempts, and she said to me, Dane, I actually don't see a lot of people come into the ER who've tried to kill themselves by suicide. I see a lot of people who come in who've tried to take pills. So I don't believe that firearms really are, kind of a leading cause. That's not been my experience. And I told her, well, that's because you don't work in the morgue. If you work in the morgue, then you're going to see a lot more people who come in who've killed themselves by firearm. So it's really just kind of a matter of understanding, the fatality rates when it comes to those types of attempts. So there have been a number of studies that have indicated that when lethal means are made less available or less deadly, that suicide rates by that method decline. And frequently, suicide rates overall actually decline. So this has been demonstrated in a number of areas with bridge barriers, detoxification of domestic gas, certain pesticides, bubble packs of medication, and a couple of other things. So that is to say that when you have, if you have a bridge and you put up barriers like big curved fences over the top of it, makes it very difficult for people to scale that fence and come over the top and jump off the bridge. So those are, examples of means reduction that actually is proven to save a lot of lives. There's actually a really interesting case in Samoa, America, where the suicide rate rose and fell with the introduction and control of a chemical compound called Barrocas, which was found in pesticides. This particular chemical is more lethal than pesticides that were previously used in the country. So when they started removing that chemical from those pesticides, they found that people were poisoning themselves less, and the rate of suicide declined dramatically. So additionally, this also happened in Sri Lanka following the restriction of more lethal pesticides. And then another example of when means reduction saves lives was back in the 1950s, when domestic gas in the United Kingdom was made from coal, and it contained about 10 to 20% of carbon monoxide. So poisoning by gas inhalation was the leading means of suicide in the UK in that time. And then in 1958, natural gas, which is essentially free of carbon monoxide, was introduced into the UK. So by 1971, 69% of gas used was natural gas. And what they discovered was over time that the amount of carbon monoxide poisonings decreased, and suicide rates overall also decreased. So it's not that people were any less suicidal necessarily during that time, but they didn't have easily accessed means to kill themselves. And so the actual rates of suicide completion dropped. So it's a really interesting study, in the way that we think about trying to prevent suicide on a larger scale. If we were reducing the lethal means that people have access to on a grand scale, you're going to see a drop in the number of suicides on a larger scale. So to clarify, though, means reduction doesn't necessarily change the underlying suicidal impulse or necessarily reduce attempts. Rather, it saves lives by reducing the lethality of the attempts. So if you've got someone who has access to pills and they have a plan to kill themselves, if they have a stockpile of medication, and these medications have are highly lethal, a way to kind of restrict the lethality of that would be to prescribe them bubble packs of medication, where they only have small amounts at any given time, or by having someone dole out their medications to them. They may still be chronically suicidal if that's been their issue, but their access to the means to kill themselves, we're reducing that. So that's the goal of harm reduction as it relates to suicide. So if someone that you encounter, someone in your home, a friend of yours, a family member, or a patient of yours, if you're a healthcare provider, has thoughts of wanting to kill themselves, call for help. But most importantly, do not leave them alone. So what we want to do is we want to get them to a crisis center. We have a variety of psychiatric crisis centers that have popped up all over the country. Generally, hospitals are going to be a safe place for someone to go, but not all hospitals are equipped with the proper behavioral health professionals to treat suicidality. It is a safe place for them to go because they're going to be monitored 24/7, but if you can get them to a psychiatric specific facility, that's going to be in the person's best interest. If someone is not willing to go, many states have an involuntary evaluation statute. So in Arizona, it's ARS Title 36. You're able to actually file some paperwork on an emergency basis to have someone taken against their will by law enforcement to a psychiatric hospital. And the goal of that is that, if someone really is hell-bent on killing themselves, and you're not able to stabilize them in their home, if they are absolutely going to do it and there's no way that you can stop them, then calling law enforcement in to keep them safe is an ideal situation. Additionally, there are mobile crisis teams, which is what I mentioned. I worked in a previous role that can come out and help keep people safe as well. I do want to make it clear, though, that oftentimes when people call 911 for suicidal folks, there is kind of a preconceived notion amongst first responders that's a little bit difficult to kind of grind out, but it's ingrained into the fabric of first responders, is that if someone is suicidal, then they're dangerous because they're willing to harm others if they're going to harm themselves. I don't really understand it, but that's just kind of the prevailing belief among some law enforcement. And this is not true of all law enforcement agencies, but some of them it absolutely is true. So know that when you call 911, sometimes you might not get EMS or fire right away. You might get EMS, fire, and law enforcement, or perhaps just law enforcement coming to escort them to hospital. So just understand that, generally that's not a great use of law enforcement's time because they're not trained behavioral health providers most of the time, unless they have a mental health support team or a CIT trained officer or something like that. So getting folks to a crisis center or a psychiatric emergency hospital is generally going to be the best way to get that done. Additionally, there are crisis lines that have popped up all across the country. There's a National Suicide Prevention line. You can give them a call. They can talk with the folks, try and kind of, talk them down. They can help you safety plan with them if it is possible to keep them safe and at home. But what really I'd like to implore upon you is thinking about ways of removing access to means. So if you have someone in your home who is suicidal, if you have guns, if you have lots of sharps laying around, if you have lots of access to pills laying around, particularly opiates and other kinds of pills that are frequently used to commit suicide, make sure that you restrict access to those. So put them all away in a safe, get them out of the house if possible, work with the healthcare providers to prescribe smaller amounts of medications over time, so requiring more frequent refills. And then, that way you're removing any ligature risks, so any, cords or things that they can, people can wrap around their necks. Those kinds of lethal means we really want to focus on the most lethal first and work our way down. Additionally, oftentimes suicide is kind of a fleeting notion for people, and things oftentimes look brighter in the morning when the sun comes up. So consider, if you are home with someone who's suicidal, what sleeping arrangements look like. Making sure that if there's a concern of elopement, that you position yourself between the door and the person, or if it's prudent and appropriate to sleep in the same bed with them, doing that as well. And then again, making sure that during the times when they're most acutely suicidal, that you're restricting access to the most lethal means. And then additionally, getting long-term treatment options put in place. So getting them set up with a counselor right away, getting them set up with a psychiatrist or a behavioral health medical professional right away. Antidepressants can be very effective at treating suicidal ideation, but they do take time to kick in. So there's a time frame where you've got to worry about, hey, we're not going to see a dramatic improvement in symptoms immediately. It's something that's going to take a lot of time as they develop the coping skills with therapists, as the medications start to kick in. So making sure that we're removing access to those means of suicide in that interim. Just a little bit about self-harm. So self-harm is generally when someone intentionally injures themselves, most commonly via cutting, burning, swallowing inedible objects, picking at scabs, opening up old wounds, those types of things. And the reason that people do it kind of varies from person to person, but some folks have noted that they feel a sense of relief when they cut, which is, for someone who's not been cutting before, is kind of counterintuitive. But there's a sense of relief that comes along with self-harm for some folks. Others prefer to feel the physical pain rather than emotional turmoil that they're experiencing. So that's another reason why they might self-harm. So when it comes to harm reduction and self-mutilation, what we want to do is you want to have wounds assessed by a medical professional to mitigate the likelihood of infection and connect the person with a behavioral health professional immediately. Because it's not always the case, but occasionally people who are self-harming may also be suicidal. So it's not always true. But if you know someone who has self-harmed in the past, it's important to connect them with a behavioral health professional immediately to assess for accompanying suicidal ideation, because that is a reality. So there are various crisis lines available regionally, like I had mentioned, and additionally there's a crisis text line. And that has become an increasingly popular option because generally the folks who are self-harming tend to be younger, they tend to be teenagers, and they tend to be female, and males as well. So we want to make sure that we're connecting them with resources so that when they have the impulse to self-harm, they have someone they can reach out to help kind of talk them through that and find a more healthy way of coping with whatever anxiety or depression that they're experiencing. How you can kind of help keep someone from self-harming. Again, we want to remove access to sharp objects. So similar to means restriction in suicide, if you remove sharp objects, the likelihood of significant harm goes down. So essentially what that means is if someone's cutting with a razor, they can accidentally cut too deep, and it can cause bleeding, it can cause the need for stitches, and those types of things. So at Sierra Tucson, what we've done is, in our inpatient unit, we've restricted access to any means of self-harm. That doesn't mean that people can't still scratch themselves. It doesn't mean that people can't still try to find like a screw and try to unscrew it, which generally is pretty uncommon at places like Sierra Tucson and other psychiatric hospitals. We've designed the facility to mitigate that risk. But some people will take bottle caps from toothpaste, and they'll twist it into their skin really deeply until it kind of creates a little burn. Other folks I've met have self-harmed by pulling their fingernails out or toenails out. So really trying to kind of get creative about ways we can make sure we're keeping people safe. So generally at facilities, we'll put people on a one-to-one, or we'll put them on 15-minute checks so that we're frequently checking in with them if they're at high risk of self-harm, so we can mitigate the likelihood of them scratching themselves and hurting themselves, and trying to help them practice more healthy coping skills. So I told you we were going to come back to this slide, so I want to talk a little bit more about some of these facts in more detail. We've got a couple more minutes left before we'll get to questions. The first part of this slide that I'd like to draw your attention to is this one right here, that 90% of those who died by suicide had diagnosable mental health condition at the time of their death. So you may have heard people say that not everyone who is depressed is suicidal, but everyone who is suicidal is depressed. So this is not true. If that were true, that number would be 100%. So there are some people who die by suicide who want to die. They may not be depressed. They may just want to kind of take control of their mortality. So perhaps they've received a terminal diagnosis, and they don't have any friends or family left, and they want to kind of maintain control of their mortality. Suicide is a way for people to do that. It's not something that we wish for anyone, because we know that oftentimes a terminal diagnosis does not always mean that it's terminal. But some people choose to take their own lives, and they don't actually have any sort of significant mental illness or mental health condition. As a mobile crisis counselor, I encountered this on a couple occasions, and one in particular just wanted to end his life due to the terminal diagnosis that he had. He was of old age, and the fact that his remaining family was deceased. He didn't have a lot of close friends or any other reasons for living, so it's something that he wanted to do. So it's something that we really try and talk people out of, but sometimes people will do it. The next figure that I want to dive into a little bit more is the fact that men die by suicide 3.6 times more often than women. This figure right here. So the reason for that is that men are much more likely to use a firearm when they attempt suicide. So the completion rate is much higher than women who tend not to attempt suicide by firearm. So with a self-inflicted gunshot wound, it causes trauma to the brain, obviously, as the bullet passes through there, and it's just a far more lethal means versus someone who cuts or attempts by pill overdose. Not saying that it's any better, it's just the fact of the matter is that a self-inflicted gunshot wound has a much higher likelihood of suicide completion, and that's what men tend to do. This figure right here, the fact that over 48,000 Americans have died by suicide, and second leading cause of death for ages 10 to 34. Just to give you an idea, the number one leading cause of death for that age group, according to the CDC, is unintentional injury. So a lot of times that comes with car accidents and those types of things. And then additionally, the third leading cause of death among that age group is homicide. So for ages 35 to 54, unintentional injury, heart disease, malignant neoplasms, top suicide as a leading cause of death. So suicide comes in as the fourth leading cause of death behind those three. This particular stat right here, the fact that suicide rate was 1.5 times higher for veterans and non-veterans adults over the age of 18, that is because, as you might guess, there's a conglomeration of variables that are at play here, but most notably depression and PTSD are pretty significant contributing factors to that. So for our vets, we have specific suicide prevention lines that they can reach out to that are specifically for veterans. The VA does a good job of connecting folks with behavioral health professionals. And additionally, here at Sierra Tucson, we even have a red, white, and blue group for veterans. They can come in and focus on their treatment, and we can help them through those kind of suicidal tendencies and thoughts and get them on the road to recovery. We are about out of time here. I have a couple more things I wanted to dive in over here, so I'll just touch on them briefly. This one right here that I drew your attention to initially, the firearms piece, accounts for more than half of all suicide deaths. And most people don't actually attempt suicide by firearm, but when they do, it's typically lethal. So that's why you end up with this 50% number. So that kind of does it for our presentation. I'm going to pop open the questions here and see what we've got. So the first question is, what are safety plans and no harm contracts? Are they recognized as valid safety measures? So a safety plan or no harm contract is an agreement with someone who says, okay, if I have thoughts of wanting to kill myself, if I have thoughts of wanting to self-harm, instead what I'm going to do is I'm going to practice this coping skill. I'm going to write in my journal. I'm going to take my dog for a walk. I'm going to call my mom. I'm going to call my friend and ask them to kind of chat with me and help, remind me what my reasons are for living and those types of things. And it's actually written out in a form, and generally it's posted somewhere where people can easily access it so that they are able to refer to it as needed. A no harm contract is an agreement that they're not going to hurt themselves. They're going to call 911 if they have the thought of wanting to kill themselves and those types of things, or they're going to call the crisis line, or they're going to go to the crisis response center or wherever. So that's what a safety plan is in a no harm contract. Second question, does asking someone if they're thinking of committing suicide plant the idea in their head if they are not suicidal? No, that's a common misconception. You can't plant it in their head, and if you talk to them about, have you thought about killing yourself, in a specific way? Do you have access to a firearm? They're not going to then go back and say, oh wait, no, I should go get a firearm and kill myself. That's not how it works. So don't be afraid to ask someone if they are going to kill themselves, if they're thinking of if they're having thoughts of wanting to kill themselves or hurt themselves. And it's an important differentiation between the two, because thoughts of wanting to hurt yourself, thoughts of wanting to kill yourself are two very different things. Self-harm does not mean suicidality, as I've mentioned. All right, the next question, what if someone says yes when I ask them if they are suicidal? So this is a really good question. So what you want to do is you want to make sure that you're not leaving them alone. So stay with them, call a crisis center, a crisis hotline if you've got access to one. If they have a therapist or psychiatrist that's available, get in contact with them immediately. But the most important thing is to prevent them from killing themselves and referring them to someone who can help. So getting them to a psychiatric hospital, call 911 if you must, or get them over to a hospital if you must. Just get them to a safe place so that they are going to be safe. All right, the next comment is, I believe law enforcement usually responds on any 911 calls when EMS or fire are requested. That does happen. It depends. There's some Southern Arizona, I know specifically about Southern Arizona. It's not always the case, but it does happen in some cases. If an individual's primary means for suicide, will they substitute another means? It depends. That's a really good question. So it can happen that way. So if someone has a specific plan, they said, yes, I am going to shoot myself, and then we take that gun away, it doesn't mean that we're totally in the clear. So, but generally speaking, if we are able to reduce that immediate plan they have, because another plan may not be attractive to them for whatever reason, maybe they consider it to be not a way that they would want to do it because it would be too painful or something like that. Those are things that we can kind of tease out as behavioral health professionals. But it is important to restrict access to the most lethal means regardless of what that is. So starting with firearms, drowning, ligature risks, those types of things. Is there a recommended suicide assessment form? So the Columbia SSRS is the one that is generally accepted as being a best practice for assessing for suicidal ideation. So that's the Columbia SSRS, and you can look that up. It's readily available on the internet, and it's a really good assessment form. Are therapists legally responsible for suicide? So that's a really difficult question to answer. I'm not a lawyer, so I can't tell you for sure. But essentially, what the important thing that you want to know is if you're a therapist and you have someone who's suicidal, making sure that you are not sending them home without making absolute certain that they're going to be safe. So the easiest thing to do is to call in a suicide risk expert, so a crisis team, to come in and give kind of a second opinion, calling a psychiatrist if they have one, and staffing it with them, taking a collaborative team approach. That way we are mitigating, that way we're kind of covering our bases and making sure if they can stay safe, that they will stay safe. Otherwise, there's no harm in sending them to a psychiatric hospital, making that referral, or completing involuntary evaluation paperwork if you absolutely must. All right. Is there any connection between suicide and traumatic brain injury? It's a really good question. I don't know. So if you want to email me, dane.binder@sierratucson.com, I would be happy to look into that, and I will happily get back with you. So now that many of us are doing telehealth, suggestions on how to best reduce harm. So really kind of reviewing things with folks during your Zoom sessions as ways to reduce access to means is going to be really important. So getting family or friends, if they live with someone on the Zoom session, would be really important. Getting them on the phone and just saying, hey, it's in order to keep everybody safe, we need to make sure that we're reducing access to means to harm themselves. Is there any way you can get the sharp objects, get the guns out of the house? Is there any way you can monitor them, until we start to see some symptom improvement? Those types of things. Generally, you're going to want to get an ROI, obviously, if that's possible. But when it comes to suicidality, we have a responsibility as behavioral health professionals to tell whoever we need to, with the least amount of information, of course, in mind, in order to keep people safe. So if you are concerned about someone killing themselves, you don't have to be concerned about HIPAA. Call 911, get a welfare check done, and that's not something that should be a hindrance in helping keep people safe. Recommendations for people with SI who are very afraid of hospitalization. So this is a really common thing that we encounter. And so that the recommendations I would have is kind of referring back to the slide where I said focusing on getting the most lethal means, restricting access to the most lethal means. Sorry about that. So if you can do that, that's going to be a great step in helping secure people's safety while they're at home. Additionally, like I said, putting a safety plan in place, posting it somewhere where someone can easily refer to it when they have suicidal ideation rise, when they have self-harm thoughts rise, being able to redirect them to their refrigerator where it's posted is a really great way for some people to stay safe. And then additionally, it's just going to kind of depend on what those plans are. If they are chronically suicidal, making sure that they're living with someone who can kind of help monitor their safety and those types of things. Really just take a tribe to keep everybody safe. Implication of conducting therapy on Zoom. I talked a little bit about that when it comes to suicidality. But one last question here, because we're running a little over time, confused about how someone drowns themselves. It's very difficult to do. It's a really good point. And what happens is sometimes people will tie things around like a cement block around their waist and jump into a lake or something like that. That's generally how someone drowns themselves most easily. It's not, like I said, it's not very common, but when people do attempt it, it's very lethal. All right, very good. Well, hey, thank you everyone so much. I really appreciate you attending this morning. Thanks for all the questions, and happy to connect with you offline if you'd like to discuss things a little bit further. Thanks very much.